technology we use for children and adults with hearing loss is to give them access to speech. That's the reason we do what we do. So, first they have to hear well if they're going to succeed. Yes, they have a hearing loss. Yes, they're fit with technology. Is the technology doing what it needs to do? So I said this before, but I want to say it again. I can't tell you how critical it is that children hear between 6 we are learning, children learn a great deal from overhearing. They learn from hearing around things around them. Everyone who's a parent has had a child say, "Why did you tell Daddy that when you thought they were in another room?" And maybe they were, not paying any attention to you. So, we all know we have to be careful around kids. But the overhearing part cannot be underestimated. So everybody who's an audiologist probably saw this once. You should have it in your brain, and if you don't, it should be hanging up in the wall in your test room. So these are the English vowels, American vowels and consonants. But Mariana Mejas, who was an audiologist here, who's now in the doctoral program in New York City, is for her doctoral work, she's trying to do this with Mexican vowels. So this should be available soon. But right now, so here are the vowels from low to high. He who would know more of art must learn and take his ease. Basically. And here are the first formant and the second formant. And you see that essentially vowels are low frequency except for E, whose second formant is above 3,000 hertz. So that's why deaf people do really well at vowels. And that's how they sound. And here are the consonants. And here are the 4 frequency bands for consonants. But I particularly want you to notice how many consonants have significant energy at 4,500 to 6,000. So what that means is all of these consonants, all have energy at 4,500 or above. If our children are not hearing there, what does that mean about their speech perception, their language learning, and everything else? And we had a kid come in this week who the hearing aid had been cut because she was having feedback. We cut the highs, and when I said to the mom, this is what the problem is, she said, those are all the phonemes she's having trouble saying. What they hear is what they say. So here's a little person who's now a CI audiologist. He's checking Raggedy Andy's ears when he was 3.5. Okay, so what does intelligible speech look like? Every speech sound needs to be audible. It needs to be audible at typical conversation, at soft conversation, in quiet, and in competing noise. We know that we talked, it's like beating a dead horse about the overhearing part, but it's so important, I just feel like I need to say it. So here is the audiology fruit or the speech banana. If you hear at the top of the speech banana, you will hear 90% of what is said. If you hear at the bottom of the speech banana, you will hear 10% of what is said. If you hear on the A line here, you'll get about 50% of what is said. So, and I think people misuse the speech banana information. The speech banana is designed to tell us where speech information is. I've heard from a lot of people that if you hear they assume that if you're hearing anywhere in the speech banana, you're doing fine. But you're not. You're missing a lot.
Can you repeat that, the A and the C?
B is 9. If you hear at the B line, you hear 90% of what is said. If you hear at the C line, you hear 10% of what is said. If you hear at the A line, you're hearing about 50% of what is said. So here is a count the dots audiogram that Gus Mueller and Mead-Killian did. What they did was they took the speech banana and they put in 100 dots. And you see there are fewer dots in the low frequencies because there's not that much intelligibility information in the low frequencies. But it's very crowded. This is the most crowded part because that's where the most intelligible information is located. And what you can do as a counseling tool is you can draw the person's audiogram on here and then count the dots and see which, the ones above are the ones that they're hearing and the ones below they're not hearing. And you can use that to say, with this audiogram, we expect you'll get about 40%, 80%, whatever. But that's not a substitute for speech perception testing. It's only a counseling tool. So here is the speech banana with phonemes on it. And the thing to remember here is that phonemes, and we saw it before, have energy in different places. So here's N, but N has energy here, and it has energy here. So you have to be able to hear in all three places if you're going to get the consonant N. Here is the consonant B. It's got energy over here, but it's also got some energy over here. And what happens is, if you're only hearing over here and maybe through here, you're going to confuse because these two are over here, but then you're missing this over here, and you're going to get confused. The patient is going to be confused about what is the phoneme they're hearing, because they're not hearing all the formants. Oh, this is misplaced. This was the, could whoever's got that turn it off? So here is the audiogram for this person, drawn on the count the dots, and these are the ones they're missing, and these are the ones they're hearing. So if you count the dots, there are 55 dots they're hearing. You can estimate that they would be hearing about 55, their speech recognition would be about 55%. Here's their hearing aid. They're only missing those dots over there. So their speech perception with their hearing aid, we would guess, would be 97%. It's just a counseling tool. Please don't try to use it as a substitute for doing speech perception testing. Okay, my view is that we need to think of the speech banana just as a way to know where sounds are, but our goal is for children to hear at the string bean. Adults may not be comfortable hearing soft speech, but children have to because they have so much to learn. So if you don't like string beans, you can call it asparagus or change it to orange and call it a carrot. I'm choosing string beans, and that's my goal as to where I want a child to hear. And I find this a very good counseling tool because when I draw the kid's audiogram and the kid's hearing aid test results or cochlear implant test results, I can show parents what I'm expecting. And I just did this yesterday with a kid who's wearing hearing aids, whose parents really needed a push to go to a cochlear implant. And, I said, look, this is where he's hearing, this is where he needs to hear. And we were able to help them understand what they were missing. Normal conversation is at around 50 decibels. Soft conversation is at around 35 decibels. If a child has aided thresholds at the string bean, we can expect they're going to hear soft speech and speech and noise. If a child has aided thresholds at 40 decibels, they're going to be hearing soft speech very softly, and they're not going to be even aware of speech and noise. Again, good counseling tool. So here is something that Sylvia Rotfleisch developed for a Hearing First workshop. And I think this is very good from a therapy and an audiology viewpoint to help understand how a child is listening. So the information about nasal murmur is at around 250 to 350. Voicing is around 500. Nasals versus the differentiating between nasals and plosives is at around 750. Vowels, diphthongs, and non-segmentals are at 1,000. Liquids and lateralization is at around 1,500. Unvoiced plosives are around 2,000. Vowel second formant is here, 2,000 to 3,000. And over here are fricatives and affricates and sibilants. So you can look draw an audiogram onto this, and you can estimate what a child is going to be missing. And again, a good way to help us understand, therapists, teachers, families understand what a child is missing and what we have to do to improve it. So let's talk for a second about hearing versus listening versus understanding. Obviously, we all know, we know this, but it's important to think about it, maybe in a different way. So hearing is acoustic access to information. Did it get in? Did it reach the auditory brain? Listening requires that the child pay attention. That's the next step. The sound can go in, but is the child tuning in, alerting, looking around? First, the child has to hear it. Then the child has to pay attention. Then the child can start to understand what the stimulus is. But if we don't have hearing, we can't get to either listening or understanding. So we need to make sure that kids are hearing in the string bean or very close to the string bean if we're going to get what we need to get. Questions? Okay. Speech perception testing. So when we're doing speech perception testing, the first thing we need to think of is what is the goal of the evaluation? Is the goal for the child to get the best possible score? If that's the case, we should use a very easy test. If the goal is to see how a child compares to their peers, how a child is doing with the technology, is the technology doing what it's supposed to do? Is whatever treatment we've given the child, medication for an ear infection, whatever, if we're looking to see whether it gets better, it's improving, the child is developing over time, we need to use an age-appropriate test. It's one of the reasons when I see a child for an evaluation, I want to know from the therapist who's working with the child, what's the kid's language level? Because if a kid has a vocabulary level of second grade, I don't want to use a preschool word recognition test. Because this child is in second grade and has to function in a second grade setting. They have to have the language of the second grade setting, so I have to be using the appropriate word list that is going to measure what needs to be measured. If we want to see whether therapy has improved the child's functioning, whether medication for ear infections or whatever has done their job, we need to look for a test that is at the child's appropriate level. We also want to identify any specific speech perception errors that a child has. When I record, and everybody here has learned to do this now, when I do a speech perception test on a child, I don't want to know did they get the word right or wrong, but if they got it wrong, what error did they make? If the word is mano and the child says bano, okay, so the child is making a B for M substitution. Then I'm going to go back to the frequency allocation table, see what frequencies B and M are at, and help me figure out what I have to do to adjust the settings of the hearing aids or the cochlear implant so that the child will be able to hear the difference in those sounds. So I don't only want to have a total score, I want an error score, because that I use to adjust technology. Okay? So when you're selecting materials, we want to test things that are linguistic. We want to select tests that are linguistically appropriate, not too easy and not too hard. I don't want to do a preschool test on a 9-year-old because it's not going to tell me anything about how this child is managing. And then we have the question of sentences. Certainly in the beginning, and still many cochlear implant programs use sentence tests as the criteria to determine candidacy. That's a problem. I think. Because as we said this morning, sentence testing is a fill-in-the-blank test. It's not really a measure of speech perception. Ideally, we should use nonsense syllables. So it's no cognitive load at all, and the person just has to figure out tell you what they heard, and we can record what their error was. So that's the issue. So we're not looking for, we're not looking to see what the kid's intellectual ability is. We're looking, in speech perception testing, we're looking to find out what they can hear. So I don't use sentence testing unless a person's feeling really bad about themselves, and then we can do a sentence test and they'll feel better because they got better on it. Monosyllabic words is a problem in Spanish, I got that. So bisyllabic words is something that would be useful. But again, this may be the perfect environment to use nonsense syllables because you could really measure perception and not have to worry about vocabulary. So factors that will affect speech perception testing: degree of hearing loss, the test stimuli you use, whether they're easy or high, and the ability of the person to process the auditory stimuli. One additional factor is speech production. If a person says the wrong thing, did they say the wrong thing because they misheard it or because they can't pronounce it? Now, if you believe, as I do, in the early auditory verbal people who said, what they hear is what they say. If a kid is mispronouncing something, most of the time it's because they didn't hear it. So that's why I look for specific errors. And then I can use that information. In daily living, people need to hear at normal conversation, which is at about 50 dB. They need to hear soft conversation, which is about 35 dB. And they need to hear in competing noise because the world is noisy and you're not going to learn much if you can't hear in a noisy situation. So here's an example. If I only tested this kid at normal conversation, he has a score of 84% and I would have thought he was great. But when I tested soft speech, he got 56%. And in noise, he got 58%. So I know that this kid is going to be struggling in school. So now I have to figure out what I have to do to fix it. Maybe I can change the settings of the technology and improve his functioning. If I can't, certainly he has to have a remote microphone system in order to be able to hear when someone's more than a couple of feet away from him. So those are the things we have to think about. How do we determine what test to use? Auditory vocabulary. You want to use a test that a child is capable of doing. And we also want to use a test that's at the child's cognitive level in addition to their auditory language level. So I think even for babies, the purpose is to confirm the threshold, to confirm threshold testing to get the same kind of information, to assess something about auditory processing, and to assess the benefits of amplification. So I think I said all these things. For noise, I want to say that classrooms are typically, a typical classroom is +5 signal-to-noise ratio, which means that the speech is only a tiny bit louder than the noise. You better be sure that this kid can hear in that classroom if you think they're going to learn there. So just because nobody ever believes it's possible to do this, I feel the need to show this slide. You don't have to memorize it. It's not on the test. But we did speech perception testing on kids from 3 to 15, 3 to 5-year-olds, 6 to 8-year-olds, above 9-year-olds. And we looked at their word recognition score, the standard deviation, and the confidence interval for male and female. And you can see that even in the most difficult noise situations, which is soft speech with 0 signal-to-noise ratio, everybody got 86% or more. So, I'm just showing this to tell you, you can do this test, just do it. So by testing in more difficult conditions, we get more information about quiet speech, we get information about how the child is functioning. We can figure out what we have to do to improve performance and to see how a child's listening. We always have this issue, I'm guessing you have it in this country also, monitored live voice versus recorded testing. Recorded testing is the gold standard. We should be using recorded testing. We use monitored live voice for very tiny people who just can't do a recorded test. But as soon as a child can do a recorded test, we should be doing it. I've been talking for a long time today, and of course I talked in between while I was chatting with people, and I'm losing my voice. If I had to do a speech perception test now, it wouldn't be fair to the kid. So recorded testing is more likely to give us a reliable result. Closed set versus open set. Closed set test means that all the choices are obvious. Either the pictures are in front of you, there's a 4 set or a 6 set thing, or you say, I'm going to be talking to you about colors. So the kid knows what the dimensions are. An open set test, there's no limit. Any word in the child's vocabulary is a possibility. Our goal is to move to an open set test as soon as possible because that is more like what they experience in the real world. So you want recorded open set tests. That's your goal. You may not get there with every kid, okay, but that's where you want to try to get to. So that's what our goal, that's what we're trying to accomplish. So why do we need to test in more than one condition? Knowing how a person hears loud speech or normal conversation is not telling you the whole picture. And unless you test in all conditions, you can't know. A lot of things affect speech perception. Monitored voice versus recorded, how hard the test is, phoneme versus whole word, open set, closed set, recorded versus monitored live voice, all presentation level, more normal soft noise, all of these things are factors. And we need to, the more information we collect, the more we know, the more information we can use to change the settings of the technology and then to tell the therapists what they have to do to improve things. Here's a very long list of things that affect speech perception, and I'm not reading it, but it's in your handout, many of which we've talked about. So here is the speech perception test form that I use. I know it has a lot of boxes. You don't have to fill them all in, but the more you fill in, the more you know. The green boxes are the ones you definitely don't have to fill in. But what I do is I want to record with the right technology, the left technology, both, and with the FM, normal conversation, 50 dB words and phonemes, soft conversation, binaural and with the FM, speech and noise, binaural and with the FM. And if you want to do sentences, feel free. I'm not doing them. But one more thing about this, about the speech and noise part. The kind of noise you use is very important. You don't want to use the whooshing noise that comes out of the audiometer. That is not at all typical of what anybody experiences in real life. And if you listen to that for a period of time, you'll recognize it's really easy to tune it out. If you use babble, the one I love is for-talk or babble. There are people talking, and you can't hear the individual voices because there are so many people talking at the same time. But for-talk or babble, you can pick up individual words, so it's distracting. So it's the most common. It'll give us the best picture of what typical hearing children, what children experience in a typical hearing environment. If you use something like 12-talk or babble, you can't recognize any of the words, and it's easier to ignore. So consider it. The more boxes you fill in, the more you know. The more you know about the functioning, the better you know about what to expect. You can use it to improve settings. You use it to plan therapy. You use it to figure out what has to happen in school. What situations can the kid hear in, and what situations are they struggling in? And if they're struggling, what do we have to do about it? So this is Mariana Mejas, who was the audiologist here, who's now studying in New York. wrote this up in Spanish so that you could all have the Spanish version of how to do speech perception testing. For very young children, I didn't talk about this, but we could, maybe, I'm going to talk about it actually. It's in some stuff I'm doing a little bit later. So she took my stuff and tried to make it so that it would be intelligible to people who don't read English. So basically, there's, as Mariana says, there's detection and then speech recognition and then discrimination. So for detection, we can start off using conversational voice, ba, 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 ba. You can use music, and eventually I want to know what a child's detection is for the ling sounds, a, e, u, s, sh, m, because I can draw that on the audiogram. Ba, 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 a should be about the same as 500, sh should be about 2,000, s should be about 4,000. So you can get a good picture of what the child's hearing and where to find it. If you want the short version, it's ba 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 sh 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 s s. The VRA SPAC is a test where, for a child who's using visual reinforcement, who's not quite ready to repeat words to you, but you want to know what phonemes they're hearing and they're not hearing. So you go ah 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 sh 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 ah 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 ah, and see if the kid makes a head turn for sh, just like they would if you made a noise on, with the audiometer, warble tones or pure tones under earphones. And you can get a picture of what, and if they can discriminate between ah and sh, those are very different sounds. But how about, can they discriminate between sh, 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 sh? It's a much finer discrimination. Can they make that discrimination? And if they can't, what do I have to do to work? How do I have to work on it? So here is a baby. Lalo, can we watch this video?
She stopped sucking. Stop sucking. Stop sucking.
Okay, pause
With
it.
VRA,
Okay. So speech thresholds, you still have bisyllabic words because that's what Spanish is. We can use, in the United States, we use spondy pictures, which are bisyllabic words. Airplane, hot dog, cowboy, toothbrush, high chair, cupcake. I can't remember what the rest of them are, but pick a bunch of them, have the kid point to what they hear, and you get the threshold for the softest level at which they can point to the picture, or repeat the words if they're old enough and can do that. And for babies, you can use body parts. Where's your eyes? Where's your hair? Where's your mouth? Where's your nose? And just get a sense of how soft it is that they can repeat, that they can identify the word. Because that's a speech reception threshold as opposed to a detection threshold where you just knew the word was present. Body parts, numbers sometimes works. Numbers is good for deaf kids in English because the numbers are all vowels. If I say, ooh, what number am I saying? Okay. Another example of tests you could, stimulus by age level for very little kids. This is a list of speech perception tests that are available in English, and I'm going to show you one in Spanish in a minute. Open set tests, closed set tests. The potato head test is a test the ESP test is available in Spanish. The potato head test is a test you could easily use. When I was a little girl, even when my kids were little, we had a real potato. and it came with the stuff. You could make, eyes, nose, ears, mouth. Now they have a plastic potato. And if you find yourself in Disneyland or Disney World or Disney any place, there's a potato head store. This is my favorite. You go to the potato head store and you pay a certain amount of money for a box, and as many pieces as you can fit in that box, you can have. And so I must have 20 different kinds of arms, 25 different kinds of hats and eyes and everything, and jewelry and bracelets and all. So you make a speech perception test. Give Mr. Potato Head blue eyes. Where are Mr. Potato Head's red shoes? There's also Mrs. Potato Head. She has some skirts, but whatever it is. And you can do this. It's an easy task. The kids are crazy about it, and it's a way of getting a good discrimination task on a child who's not yet ready to do standard testing. These are open set tests that we use for young children. The alphabet test is a test that comes on a Lucite board. It's got all the alphabet letters. You could do this in Spanish. And you say, show me B and Q. And the child points to them or doesn't. And when you score them, you score it by how many distinctive features the child is off. If I say show me B and they show me D, but that is a place difference. If I say ba, ga, and they say ga, it's a voicing difference. So you can look at what the specific error is, and you get different points for how bad the error is. So it's a very good way to really understand something about perception for a child who's not repeating words. These are the tests that are available for profound hearing loss in English. And here are the tests that are available in Spanish. Closed set tests, open set tests, and sentence tests. I've told you how I feel about sentence tests already. So, but that's a clinical decision that you all have to make. Okay, so we start off by looking for a child's auditory age, and I think that Mariana made this test. Okay, this is not the right, where's her slide? I'm looking for, okay, here. So if a child is cognitively or language-wise less than 2 years, you would use the ESP, you would use the PIP 10 for the child who's 2 to 5 years, this one, the PIP 25 for 4 years to 6 years, I can't pronounce that, for 5 to 8 years, and then this one for kids who are over 8 years. So let's go back here and let me try to explain to you. So I'm looking at the child's auditory age, and it's the same. This is the same thing that Mariana showed in the other slide. I'm looking to figure out what the child's language age is so I know where to start. Once I figure that out, so I start, let me do it in English first, and then I'll go back to the Spanish, because it's easier for me. I know it's not easier for you, but I'm standing up, so I get to decide. Okay, so if I'm doing a test at 50 decibels, if the child's score is greater than 50, is less than 50%, I have to go to an easier test, because this test is too difficult for the child. If the score is greater than 75%, I have to go to a harder test, because this test was too easy. If the score is between 50 and 75%, I got the right level of difficulty, and I'm going to do I'm going to be able to test soft speech and speech and noise. Does this make sense? I'm either putting you to sleep or I don't know what's going on here. All right, so let's go back to Mariana's list here. She's done the same thing. If I'm assuming it's the same thing, but but since I can't read it, she starts at 50 dB. If your score is less than 50%, the test was too difficult, you have to do an easier test. If it was greater than 75%, it was too easy, you need to do a harder test. If it was at between 50 and 75%, you can do, you're at the right level, you can test soft speech and speech and noise. Okay? All right. And here is just the example with the new chips. The new chips is a test that is designed for children who are 3 to 5 years of age. So if you got a poor score on that, you'd go to the ESP, which is an easier test. It's a closed set test. If you got score of greater than 75%, I would use those words because they're the right vocabulary level, but in an open set format. If they got between 50 and 75%, I could do soft speech and noise. If they did well over here, I could also go to soft speech and speech and noise. Basically, the idea is I want to test normal conversation, soft conversation, and speech and noise. Here's just the same example with the PBKs, which is a kindergarten vocabulary list. And here again is Mariana's. She put the drawing on the bottom to show what it is that we're testing. 250 to 800 hertz, right and left individually. I don't care about binaural. I'm looking for thresholds here. Normal conversation, right, left, binaural. Soft conversation, binaural and with the FM. Actually, this should be a check over here also. And in normal conversation with competing noise, binaural and with the FM. Those are the test conditions we should be doing. We should be doing this on every kid. And we did a lot of these this week. So, I mean, the thing that's a problem for speech perception that you need to know is that you need at least 1, 2, 3, 4, 5 test lists. And then if you're going to use the FM, you need 3 more. So you need to just know that you need, ideally, you want 8 lists. And you don't want to have to go back and repeat list 1, because then it's familiar and you're not sure you're getting the right thing. So you really want, when you're developing all your word recognition tests in Spanish, please have at least 8 word lists, preferably 10, so you can make a mistake and go back and fix it. Okay, here is this child is 2 years and 9 months of age. He has had a cochlear implant for 6 weeks. And I just want to show you that you actually can test little tiny people. This is not, this is in an office. It's not in a quiet test booth. I'm just looking for how he's doing so I can figure out what I have to do next.
Words? Okay, listen. Prune, mood, blow, roam, roam. Good job. Blow, gum, bug, boat, ball, pound, rat, dad, lamb.
So, I mean, just so you could see that we do this on little tiny people and it works. Okay, so this is a kid we saw this week. She's had her cochlear implant since July. She got turned on in the middle of July. She has 1 cochlear implant, and we did speech perception test. She's 4. We did speech perception testing with her yesterday. Okay, we could stop. I mean, she's 4 years old. She's had a cochlear implant July, August, September, October. She's got a cochlear implant for 6 months. This is a recorded speech perception test. Could not be more reliable. That's what happens when a kid gets identified early and has good auditory verbal therapy. She went into the cochlear implant prepared because her brain was already auditory. She didn't hear everything she needed to hear, but she had auditory skills. I'm very excited. I'm glad I got to record that yesterday. Okay. Using speech perception information to change technology settings. Anybody have a question until now? Okay.
Yasmin, estas pruebas generalmente en cabina, ¿verdad? O sea, sí entiendo que se pueden hacer afuera, pero lo ideal es que se hagan en cabina, ¿cierto?
She's asking if these tests have to be done in the booth.
They should be done in the booth. That's the idea. But you should do them, I mean, if you're doing therapy, do them in therapy and say to the audiologist, these are the places I'm seeing this child having a problem. Okay, this is the medial consonant test. It was developed in Iowa to use for cochlear implant patients early on. What you do here is it has got the consonants listed here and the number of times it's presented is based on the number of times the phoneme is likely to be present in English. And what you do when you present it is you go, the first, it's ata. I don't expect you to read this, but it's easy to, it's available online, and if you can't find it, email me, I'll send it to you. Ata, ava, ana, aba, ama, so you use the vowel a, and then put in each consonant. And as in everything else, you don't just record if they got it right, you record what the perception error was. What is the confusion? And I do it with the vowel a, and you can also do it with the vowel e, which is a high frequency vowel and will change the performance. And then I record that information, look at the perception errors, and figure out what I have to do. Can we show this video? This is a 3-year, 6-month-old. She has had a cochlear implant. She came from another country where she got no services. She came to the United States when she was over 2 and 3 months, I think. Didn't speak English, family spoke something else, educated parents, came to the United States, spoke, and she's got implanted, has been in auditory verbal therapy, and this is the medial consonant test on this kid. Abba.
Aba,
Perfect. Good girl. Ata.
ata,
Oh. Ava.
ava,
Excellent. Ana.
ana,
Apa.
apa,
Good work. Ama.
ava,
Aga.
ada,
Ada. Good. Aka.
aka,
Aza.
ava.
Oh, good. Okay, you get the idea. You don't have to listen to the entire medial consonant test to see what which is boring. But, but it's very, this is one of the most useful pieces of information I have when I'm trying to figure out what to do to deal with technology for a kid. So then you just take this information, you write down the errors. I think I have her errors here. And then I go to the frequency allocation table and say, where are the, and I look, okay, this kid's got a lot of errors in phonemes that have energy at 2,000 hertz. So then I know I have to try to increase what's happening at 2,000 hertz so I can try to see if I can improve the situation. Possibly, they may have too much low frequencies or too few low frequencies. So you need to play around with it, but you should be able to make an immediate correction when you do this. I do it, the map or the hearing aid settings, go back, repeat the errors, and see what happens. And you should make a very, very quick change. Here's the list of speech perception tests by age. that we use in the United States, what we do when. They shouldn't have X's, they should have checks. I should do something about that. Okay, so how do we describe auditory performance? Unaided, this is what he hears. Aided, what does he hear with the right technology, the left technology, the two together, and the FM system? What at normal conversation, soft conversation, in competing noise, you may want to add, clued materials, he gets this score, unclued materials, he gets this score. Phoneme versus word versus sentence information. And sometimes, although it's hard to figure out how to interpret this, first presentation versus repeated presentation. On the first presentation, he got 64%. On the repeated presentation, he got 86%. So we got a little bit of a clue. If you said it a second time, he was able to get more. So I think, I think it's important to talk about how you describe speech perception. We talked about this morning a little bit, how we use the information to determine what the score is. And I think it's important that we do it this way to be honest with families, so that we can say this child has good speech perception here. Or this morning I wrote a report. The kid's best speech perception was 44%. How's this kid managing in a second grade classroom? So what do we have to do in that classroom to help him succeed? I'm not saying take him out of the classroom. I'm saying this tells us that we need to make sure someone has taught him the vocabulary before he goes in there, and someone is reviewing the vocabulary and the concepts when he leaves the classroom. So it's telling us what to look for and what we have to do about it. And if speech perception is poor, fix it. So we need to describe it accurately. Let's look at a few cases. What time am I supposed to be finished? Question.
Yeah. What would you do if you were testing a child who has a speech or articulation problem in the consonant test? That's a really hard question. What do you do when a kid's got artic problems? Well, the question is the artic problem the result of a hearing problem? If they didn't, you can do a number of things. Like did you say boat or moat? Boat, like the thing you go in the water, or moat, the thing that's around a castle? You can ask, give the child the two choices and the child will tell you which one. You can, if a child is older, you can have them write what they heard. So there, there are a number of things you can try to figure it out. So here's a child who's had essentially normal hearing, but middle ear stuff, and probably an auditory processing disorder. So this child's got great speech perception at normal conversation and quiet, good at soft conversation and in the first noise condition. But if I'm doing auditory processing testing on children, I'll test in two more difficult noise conditions. And here I can see he's really having problems. Here's a kid with air conduction thresholds 20 and 15, bone 4 and 6. So I know there's some middle ear thing going on here. Speech perception, you can see what's happening. So here's Lizzie, she's doing great at normal conversation, very bad at soft speech and noise. With a remote microphone, she's doing great. If I do something, when a kid is resisting wearing a remote microphone, you do that kind of testing, and at least they have to admit they hear better, and the parent has to admit they hear better, even if you can't get them to do it. But you've got to give them the information so that they're making an educated decision. Here is Avi, 96% word recognition in the right ear, 84% in the left ear. Again, not good at soft speech and in noise, but great with a remote microphone. So here is a kid with a profound hearing loss. On the new chips in a picture pointing format, he got 60%. In an open set format, he got 16%, which would be more appropriate for a 9-year-old. And then the AB lists, you can see the differences there. So that's if you don't use the appropriate test, you get a messed up score. This kid is really functioning like 16%, not 60%. So here's a child, 84% with the right hearing aid, 64% with the left hearing aid. Uh-oh. What am I going to do about that? In this 80% binaurally. If you've got poorer speech perception in one ear, you have to do something to build the skills in that ear. First, check the technology. Is it working? If not, do listening therapy with the left ear alone to build the skills in that ear. I am telling you, it will build the binaural score. Here's the opposite. Poorer speech recognition in the right ear, drawing down the binaural score. Why is that happening? I'll give you a clue. Right ear, left brain. Language is the left brain activity. So the right ear is poorer, and that's going to it's bringing down the total score. So here's a kid who the bilateral cochlear implants since 18 months. The Cochlear Implant Center tested him. He's 9 years old. They tested him with a kindergarten word list. He got 98%, and the school said, he's cured. We don't need to do any services anymore. So we retested him, and with an age-appropriate speech perception test, he's got 68%, 72%, 76%, and poor results for soft speech and noise. So first of all, we knew what we had to do therapeutically, and secondly, we could tell the school that he needed services. So, what's good enough? From my viewpoint, 80% or higher is our goal for speech perception in the kids that we see. Do kids with CIs need to hear as well as typical kids? Do kids with hearing aids need to hear as well as typical kids? Yes. So, when you're looking at scoring speech perception tests, if speech perception is good at a loud level, you know that the patient has the ability to use speech to understand. If speech perception is poorer at normal conversation, maybe we can do something to make the signal louder. Same for soft speech. Are right and left ears the same? If they're not, check that the aided thresholds are the same. Do therapy with the poorer hearing ear, listening practice, 2 to 3 hours a day with the poorer hearing ear alone, not in school. And consider doing a lot of auditory therapy with the poorer ear alone. Word scoring versus phoneme scoring, we've talked about. I think we really need to do both. We need to understand what a child is hearing. Therapy should work on improving speech perception and also difficult to hear sounds. Again, speech and noise. If a child is hearing well at normal conversation, we expect them to be able to hear at 6 feet. If they are not hearing well at normal conversation, it'll be difficult for them to hear in a classroom. So we should try testing at louder levels to see what they're capable of, and try changing the settings of the technology and retest to be sure it's better. Auditory therapy. If they hear well at soft speech, they'll be able to hear at 10 feet. If they don't hear well at soft speech, it'll be difficult for them to hear. Try changing the settings and seeing what you can do. Definitely use an FM. If they're having trouble in normal conversation in noise, if it's good, they'll do well in most situations. If it's poor, they'll have difficulty hearing in the classroom, on the playground, in lunchroom. And so we need to make sure that we have a remote microphone for them to use in all those situations. And even if they're doing well, they're going to be exhausted at the end of the day. So we need to, how do we really know about function? Unilateral hearing loss. Somebody asked me about a unilateral hearing loss before. When I see a unilateral hearing loss, I test with speech on the side of the bad ear and noise on the side of the good ear, making the most difficult condition so you can get a real sense of function in the classroom. Thank you for listening. Any questions? Okay. Thank you.